Trying to teach people resuscitation, you very quickly realize that the medicine is not the tough part. And you all know this from your work in the emergency department. The tough part is actually doing it. And we're really lucky as educators in medicine. We get a whole bunch of incredibly intelligent, motivated, talented people, stuff them together. They all want to learn the things that we want to teach. And so really, for the most part, it's pretty easy. But every now and then, you come across people who have a hard time learning some of the skills that we do. And to try to figure out how to help them, you really have to understand in a lot of detail what actually it is that we're doing. And so that pushed me personally towards studying leadership. Now, I think of leadership as large L leadership and small L leadership. Large L leadership is the stuff that some of you will aspire to, the administrative roles, whether you're leading your department, leading your university, or if you have political aspirations, that's big L leadership. The little L leadership that we do all the time, and I would say it's actually probably one of the most important parts of your job, is the small L leadership where you and a small team of people work really hard to try to save somebody's life. There's a number of components that go into that leadership, and one of the really neat ones that has progressed a lot in the last few years is around decision making. Now, emergency physicians, I think, are some of the most impressive decision makers out there. If you think about it, it is really the most important thing that we do. And it's what we do that differentiates us from other members of our team, and it totally really differentiates us from other lines of work. The way that we make decisions makes us very different from other specialties. If you think about internal medicine and how they come to a decision compared to how you come to a decision, it's a very different thing. And so what I'm going to talk about today is some of the new things that have been found out in the psychology literature, and it taps into neuroanatomy as well, but it all applies to the stuff that we do. And I'll talk a little bit about the research that my group is doing in Kingston, looking at leadership, small L leadership by emerge physicians. So if you're going to understand decision making, we really think of decision making in sort of three phases. First of all, you have to have sort of your perception or your understanding of the world. Then there's the process of weighing your options and exactly how we do that. And then finally, there's the moment of decision. Now, perception. So there is a real world out there. And although there are a few philosophers who disagree, most of us will agree that there is very much a real world that we're working in. The trouble is, we don't actually know it very well. What we do is we get little pieces of it from the things that we see, the things that we touch, smell, and in our heads, we create this model of what's around us. That model is not perfect. It's a good representation, hopefully, of the world around us, but it's not perfect, and it's not totally accurate. What's interesting is how different that world is from the real world. And this is one of the things that science has really been demonstrating very nicely. If you're trying to find the best option, you tend to spend a lot more time, and you have to worry a lot more. Makes it a lot more challenging. All right. Next, we get to actually making the decision. This is a tough moment to define, at least from the outside. It's pretty easy on the inside most of the time. Usually you've got a pretty good sense of when it is that you've made a decision, but it depends on a couple things. So first of all, the urgency. So the more pressure that you feel, the more likely you are to make the decision quickly. That makes sense. But along with that, the other big thing that is in our line of work is the fear of error. Because quite frankly, decisions that we make are really pretty high stakes. They're pretty important. And so there's a part of you that really, really doesn't want to do it wrong. And so that puts the brake on. And it's that balance of those two things that really influences how quickly someone makes a decision and whether or not they'll move on from that decision. So the novices that we studied, they use something called decision deferral. Decision deferral is a way of dealing with that horrible pressure of urgency and fear of error. And basically what you do is you pass it on. So probably the most common extreme example of decision deferral is to flip a coin. What do you want to do? I don't know, let's flip a coin. So you've deferred the decision onto some sort of random kind of event. Sometimes decision deferral is appropriate. That's where you say, you know, I can't make this decision. I think we need to talk to the attending. That's fine. But there's another kind of decision deferral that we found pretty common in clinical medicine that is really not quite as good. And that's where you depend the decision on something that's going to happen in the future that'll just take it out of your hands. So for example, patient's hemoglobin comes back at 82, and you haven't decided whether you want to transfuse them or not. So a common decision deferral that'll be done by an R1 in surgery will be to order another hemoglobin and just decide that if it's now less than 82, I'll transfuse, and if it's 83 or more, I'm not going to transfuse. That's not a great way to make a decision. Urgency uncertainty. This is a real challenge for our learners. And it's the sense of urgency going in the wrong direction both ways. So sometimes someone who is a novice doesn't recognize that something is a crisis. And that's a problem, right? And so they may not have the same kind of urgency that they should have to make a decision. But it goes the other way too. And in fact, sometimes I think this is probably more common than the other way. And that's when someone makes an emergency out of something that really isn't. That's an incredibly challenging skill, and I think is one of the hallmarks of a true expert in emergency medicine. The ability to recognize when it is not a crisis. When you can make everyone in the room just slow down a little bit, take a breath, and do a better job of what they're doing, and you actually transform a crisis into something that's not a crisis. It's a great gift, but it requires experience, and you can only do it with experience. Experts, they also make synergistic decisions. Synergistic decisions are fantastic. They're a beautiful thing to watch if you're interested in decision making. That's the ability of a clinician to deal with uncertainty by making decisions that satisfy both possibilities. So for example, you've got somebody who's really, really sick, and you're not sure if it's an MI or a PE. They're too sick to go to the scanner. The cath lab's going to take too long. And so you decide to thrombolize them because it'll satisfy both. Right? The ability to satisfy both options at the same time is one of the hallmarks of an experienced decision maker. The other great thing that really good decision makers do is they find a position that is referred to as confident humility. And this is something that a group at Harvard spent a lot of time studying, and they studied anesthetists in the OR doing simulated crises and tried to find the most successful decision makers. The problem with decision makers tends to be that they'll go too far in one direction or the other. And that is, they'll make their decision and hold on to it and not be willing to let it go, or they can't make the decision, right? They just can't pull the trigger. The people who are really good find a place in between. They make a decision, even though things might be still uncertain. They move forward, but they accept the fact, they hold on to that decision lightly. And they describe it, it's like trying to catch a small bird, right? You actually have to commit and do it, but just hold it lightly. And that's the way good decisions should be too. I've talked a lot about how good it is to be an expert decision maker. And hopefully the residents by now are starting to get the idea that they should have a tremendous amount of respect for their senior attendings. There's a downside though. And that is what we described as exaggerated experience. Who are the folks here who've been practicing more than 10 years? Show of hands. Great, more than 15? Okay. The people who've had their hand up now can probably, without taking any time at all, think of 4 or 5 really horrible cases that they've had in their career. Is that true? Derek, you at 4 or 5 yet?
Never had a bad case
Never had a bad case. There's also, so as I said, with novices sometimes, they don't have a really good situational awareness. You know what I mean by the bad cases, right? One of my bad cases I will share with you was when I was an R4 and I saw a poor young lady with Crohn's. She had been in for surgery for a couple of weeks earlier. She came in with belly pain. And really, she was fine. And to tell you the truth, she was kind of whiny. She was a little bit of a pathetic thing. And really, her problem was that she was constipated. She'd been taking too many Tylenol 3s for too long and was all bunged up. We gave her some enemas, cleared her out, and I discharged her to go home. I was then up in the resuscitation room and got called back to sort of our more minor area where I'd been seeing her because she fainted. Now, at that point, I had enough experience to know when I walked in that she hadn't fainted. She was still on the ground, despite the fact that it took me probably 5 minutes to get there. And any of you who have gone to see someone who's fainted know that if they've fainted, by the time you get there, they're awake again. She wasn't awake, and she didn't look like someone who fainted. She looked like someone who was arresting, and that's what she was doing. And so we moved her up to the resuscitation area, and we worked on her for about an hour and 45 minutes. And she came back, and we kept losing her, and she'd come back, and we'd lose her. And it became fairly clear that she'd had a massive PE. It was one of those PEA arrests that keep teasing you, by getting circulation back, but it only lasts for 4 or 5 minutes. And we thrombolized her, and we did everything else, and she ended up bleeding out through a liver laceration that she got from her CPR, and she died. I went back through the case, and there was nothing about her presentation at all that suggested that she would have a PE or a DVT. And in all honesty, I don't think she had, I think she had a DVT that was silent that we didn't know about. She didn't have any signs of a PE when she came in. It was just really unlucky that when she got up from the bed at that particular point, she had her big PE. Now, she had red hair, and I remember her quite vividly. And in fact, when I look at some of the people in the audience who have reddish hair, I can identify you very quickly. And to this day, when I see anybody who has that look, I think of PE. Every time. I also think of Crohn's, patients with Crohn's. I also think about whether they might have a DVT or a PE. And that's not actually appropriate, right? That's wrong. And that's because, from my experience has led me in that direction. Now, it's fine when you've only got 1 or 2 of those. It's not too much of a problem. It's interesting talking to people who are coming to the end of their career or who have recently finished their career, and they talk about how things are in those last couple of years practicing emergency medicine. And the problem is that those ghosts haunt you. And you just get to a point where there's too many. You really can't make the decisions the same way anymore because there are so many of those people hanging around in your closet that it gives you that hold back and you can't commit anymore. And that is one of the biggest challenges that experienced physicians have to look to. And it's trying to figure out whether you can still purposely and consciously overcome those or not. That really determines, I think, that's part of what determines the longevity of an emerge physician. All right, implications. So what does this mean? Well, it means a few different things. And I think this talk has been, this is not the usual kind of grand rounds talk, at least not the kind of grand rounds talk that we have in Kingston. Usually we talk about medical stuff. But there's a lot of understanding about the way our minds work that is really been percolating to the surface in the last few years. And it is incredibly relevant to us. This is what we do. I think that you should think of your brain in the same way that an expert athlete looks at their body. It is your livelihood. It's what you're getting the big bucks for, and it is what is sort of making you your livelihood. And you can be good at it or bad at it, and you can take good care of it or you can harm it. It's up to you. But we are understanding more and more about how it works. And so I think it really behooves us to adjust the way that we practice and also adjust the way that we teach to meet with this understanding. So some of the implications, I think, are, first of all, we have to train our System 1. It's a little bit scary, but that's the thing that's in charge. Okay? Remember, it's your System 1 that decides whether or not to kick something up to System 2 or not. If you train your System 1 poorly, you will automatically do things incorrectly, and you will never know the difference. So it's really important to train it well. And we do that by consciously creating good habits. There is a real advantage to debriefing. It's not just something for the simulation lab anymore. Any kind of significant action in your emergency department should have a debriefing, because that's when the learning happens. But it also means that follow-up's important. One of the hardest parts I found about emergency medicine, and one of the things that I really enjoyed about doing ICU, was that in the ICU, you get to know the results of your decisions over a period of time. And one of the problems with eMERGE is that somebody comes and steals our patients from us. And if you don't actually work to follow up to see what happened, you don't know if you did a great job or if you did something terrible. You got to treat your System 2 with some respect. So System 2 is incredibly energy draining. And I think we really fail to appreciate how incredible it is. It is really, I think, the thing that makes us different from the lower level animals. System 2 is essentially a way of trying to predict the future. That's what the big part of your brain is for, right? And that, you can imagine that was really useful on an evolutionary basis way back when. Still is pretty useful. But essentially what you are doing with the big part of your brain is using what you've known from before and anticipating and predicting what the future is going to be and acting on it. That's what makes you different from, the lizard who's crawling around on the ground, who's living in the moment. Think about that the next time someone tells you to live in the moment. Okay? It's not all it's cracked up to be. It's so valuable, and this is a little bit of an aside, we've got a little bit of time. It is so valuable that what we sacrifice for it is sleep. Right? So you require sleep. From an evolutionary point of view, imagine the first animals that decided if it was a decision, and it wasn't. But just imagine that what they're sort of gaining must be so good that it's okay for half of the day to go into an unconscious, completely vulnerable state to recharge. Right? That's crazy. That is not something that anyone would purposely decide. Certainly no administrator would decide right now if we had the option of going with this or not. They would not go for this level of function. But that's what System 2 is all about. It's that big part of your brain. It takes a lot of energy, and it will work in really difficult circumstances, but it works better when it's not. So that means getting enough sleep. That means making sure that it gets breaks. Making sure that it's not constantly in a stress state, making sure that it gets away from medicine for a while, and taking good care of it. And it will work much better for you if you do that. And I think the thing that we should be striving for is what that Harvard group described as that confident humility. So see if you can get yourself to a point where the decisions you make with confidence and move forward. But hold on to them lightly. Because remember, our perceptions are not always what we think they are. Looks like we've got about 5 or 10 minutes. Does anybody have any questions or comments?
Kind of seen it?
That's a great point. So are there lessons to be learned from the airplane industry? I think that there are, and I think that we have learned a lot about how we work, and particularly the way that the air industry has gone is by looking at errors, right? And the errors that happen, and they've identified the things that we refer to as cognitive biases, right? And you've all heard these biases before, and we're told about them, and we're told to worry about them. And I think there's a lot of validity in understanding those. At the same time, though, there's a real problem with looking at the way we think from the biases and error point of view. The biases that are described are almost universally describing a way that your brain tends to work. Your brain works like that for a reason. And usually, with most of the biases that we talk about, the way that you're thinking works the vast majority of the time. And it's only the time that it made a mistake that we call that an error and a bias. And the reality is, I don't think you can get rid of a lot of those automatic kinds of things. I think they have to be there. And in fact, they're there for efficiency, and they make our brains work as well as they do. It's good to recognize that those systems sometimes can go wrong, and why sometimes we might want to put the brakes on them. But the reality is you can't get in the way of them all the time. The other limitation from looking at just the airline industry, I mean, really the reason that we look to the airline industry is because they've done this for so much longer than we have. But they're in a very different situation. They spend most of their time flying perfectly healthy planes around, trying to prepare for the occasional time when something goes wrong. We're in a very different situation. We always jump on board a crashing plane, right? Every single time the stupid thing is crashing. It's all that we do. We get in crashing plane after crashing plane after crashing plane and try to land them. And so our approach is a little bit different. With all due respect to things like the use of checklists, there's a place for them, but it may not be as easy to adopt into the realities of emergency medicine as we might think. But I think there is certainly a lot to be learned from them. We just have to be picky and choosy about what it is that we decide to go with. I will say that the pilots point out that the other difference between pilots and doctors is that pilots are actually on the plane, so are a lot more invested. I don't think it's entirely true. I think we're pretty invested, but I can see how it would be a little different. Yeah.
So did the Harvard researchers identify interventions that would help get clinicians to the place of confident humility? Because as someone who has been the nurse assisting the physician with confident humility and the physician without, it makes a massive difference in the experience of the entire team, I would say. So how do you get people to that stage of the sweet spot?
That's a great question. So how do you get to confident humility? I guess the problem is you have to get to both. And when we identify residents who are in trouble, or sort of the resident who is having a very difficult time doing well, it's one or the other. So there is one group of residents who completely lack confidence. And so they will not move to that point of making a decision, right? They will continue to collect more information. They use decision deferral a lot. They'll try to bump it off to other people or other things. They just cannot pull the trigger. There is also a problem the other way, the lacking humility. Now, I would point out that we're talking about humility not as a personality trait here, but around the decision. They do often go together, but not necessarily. And so you can be very confident, but also very humble. It is a balance. That humility is just that ability to re-look at a decision if things don't seem to be going quite the right way. So if it becomes more and more possible that the decision you made was an error, it's that ability to let it go. I think these things can be taught. We're just starting to understand that they exist. Figuring out how to teach them is really challenging. And I think part of the problem is that we may need to accept that there are some people who cannot be taught. And I think there may be some of these things that are really more based on personality and personality traits, and sometimes, quite frankly, in the really pathological groups, it actually it gets more into the realm of a psychological disorder. But if we can at least identify it, then if nothing else, we can counsel people into other lines of work. But I think as educators, that's one of our responsibilities. We have a responsibility not just to our learners, but to society as well. And we need to make sure that we can make people who are at least somewhere close to having that balance. If you didn't hear the question, so the question is about cognitive load. And is there any advantage potentially in having designing emerge shifts around the issues of cognitive load? So for example, you start in maybe some of your heavy hitting part of the emergency department for your first 4 hours, and you do your second 4 hours in a less acute area. So I guess I think this is a really fascinating area, and this is actually the area that we're doing our research in right now, is trying to measure cognitive load. Because you can actually look at physiologic variables like pulse and what's called galvanic skin response, which is basically a lie detector test, but also pupil dilation, and you can measure how cognitively loaded someone is. And I actually think what you're talking about is what I would call cognitive endurance. So, and it's related to cognitive load, but this stuff all has sort of physical analogies. But when you go into a resuscitation, you are doing some pretty heavy lifting cognitively, and you are dealing with a whole bunch of different things all at one time. And there are certain things that we need to do to try to preserve our ability to deal with that cognitive load. But by the same token, if you were to go in and to lift a whole bunch of heavy things repeatedly, you would start having troubles with your cognitive endurance. And it's both length of shift, where you're working your shift and what kind of things you've run into, but also time of day, right? Which has a really big impact on your ability to deal with those kinds of things. So I think both cognitive load and cognitive endurance are really important. One of the problems that we're finding looking at cognitive load is that if you give easy questions to somebody and then a tough math question, you can measure their cognitive load and you can see the difference. If you take a novice and give them a medical problem and an expert and you give them the same medical problem, the expert is less cognitively loaded. In a simple resuscitation scenario, a novice is going to be cognitively loaded and an expert is not going to be as cognitively loaded. But in a really challenging resuscitation, they're both going to be maximally cognitively loaded. The expert's just doing a whole lot more. So an R3 who is running a resuscitation of a really tough trauma patient. Okay, so we just had a case last week of a 17-year-old who was in a very bad motor vehicle accident in a car with 6 other teenagers. 4 of them were killed. 2 of them were brought in very sick. This guy was a 17-year-old without a head injury who was exsanguinating. So that's a really, really, really high priority case, right? This kid is savable. He has not got a head injury. When he first came in, he was confused, but he was talking, but he was exsanguinating from, at that time, a lacerated lung. So an R3 in that position is going to be fully cognitively loaded. They're going to be fully cognitively loaded by the things that are happening in the room, having to perceive what's going on, trying to organize their team, and trying to remember their priorities for treatment care. An experienced physician is going to have mentally done all those things in seconds and is going to be working on all kinds of other things. Is the OR ready? We've got to get the surgeon in the operating room. We've got to clear the operating room. I've got to deal with the charge nurse in the OR who is saying, we really don't have time to do that. Right? All those kinds of things that are happening, but they're both going to be fully cognitively loaded. They're just doing really different things. It's just like playing hockey. Right? When I play hockey, I can skate without thinking about it, but I cannot pass or shoot without concentrating. Okay? I'm not a very good hockey player. When Derek plays hockey, he skates, passes, and shoots without thinking about it, which frees up his brain to think about other things like strategy. Right? There's no room in my head for strategy. And it's exactly that same kind of thing. But we all have a cognitive limit, and it's frighteningly small. But we all have it. We just use it a little bit differently.